Hello everyone, my name is Natalie. I'm going to talk today about hematologic emergencies, and my mentor for this was Dr. Alfred Lee. Our talk will be broken down into the different topics. It's a little bit different from the other Yale20s because there's a lot of different heme emergencies. So today we will talk about what are the heme emergencies to be aware of, the diagnosis and etiologies of each one, treatment and management for each one, and finally the assessment and plan. Breaking it down, I think it's helpful to organize the issues by the organs. We will not go over everything, but just as a brief overview of the different classifications, you can think of them as metabolic, neurologic, cardiopulm, hematologic, and infectious. For case 1, we have a 41-year-old lady. She has acute leukemia. She is inpatient, and today is day 8 of induction chemotherapy, 7+3. She develops a fever to 101.6 degrees Fahrenheit. Things that you want to look for are history of infection or prior infections, and quickly look at the medication list when the nurse calls you to the bedside. And then when you look at the patient, things that you want to focus on are physical exam. You want to look at potential sources of the infection. So in particular, you want to know if the patient is ill appearing or not ill appearing. You want to look at things like skin to see any lines or wounds that may be a source. You want to look at the oral mucosa, that sometimes there's a lot of breakdown, or they may have infections in the dental area. Listen to their lungs. That's helpful to know as a starting point if there's any underlying lung pathology. The usual things that you want to look at are your pleural effusions, if you hear diminished breath sounds in one particular area. Also, you want to look at, are they in any respiratory distress? Are they coughing up any sputum? The belly also is a common source of infection. You want to feel the belly if anywhere is distended, if there's any particular pain in the belly. And then don't do a rectal exam on someone who is neutropenic, but you can look around the anus to see if there's any skin breakdown, any wounds as possible sources of infection. So of note, it is often really difficult to distinguish life-threatening infections from the less serious infections in this patient population. Oftentimes the signs and symptoms are muted because they don't have the neutrophils to mount a huge inflammatory response. You want to look at the labs. In this particular case, the pertinent labs for her will be, she has leukopenia, she's neutropenic, and she's just in general pancytopenic due to her induction chemotherapy. When you're triaging people, things that you want to consider is hemodynamic stability. Do they need pressors? You want to look at their airway. If they're in a lot of respiratory distress, say a lung infection, do they need to be intubated? If they have a change in mental status, if they become very lethargic, or if they become obtunded and may need to be intubated, those are indications for going to the ICU. First step down is if they don't need pressors and if they don't need intubation, but they just look quite ill, they need closer nurse monitoring. And then if you keep them on the floor, is sometimes people can have a fever and they may look and feel totally fine. And you just want to make sure that you continue to watch them, but they may not need such a high level of care. And we just tell everyone who is outpatient, or if you're triaging in the emergency room, neutropenic fever is basically an automatic ticket to the hospital. The definition of neutropenic fever is a temperature of 100.4 over 1 hour. You can also consider anyone with a temperature of 101 at any given point to have a fever. Neutropenia is an ANC below 500. ANC is calculated by the white blood cells times the PMNs and bands. The magic number for us is below 500. For the labs, you want to work up the potential source. because source control is the most important part of neutropenic fever. Things you want to get are CBC, BMP, LFT, lactates for everybody. You also want to get blood cultures. At Yale, we like to draw blood cultures from the central line and also peripherally. You want to get a chest x-ray, urinalysis plus minus urine culture, and then depending on the presentation, you want to get either a sputum culture, stool culture, or even a CSF if you're doing a lumbar puncture. Just of note, in neutropenic patients, the neutrophils are what creates the infiltrate on a chest x-ray, and oftentimes because they don't have the neutrophils, they can't have anything show up on the chest x-ray. So a CT is much more sensitive, and sometimes, depending on how sick the patient is, we'll jump straight to the CT. Source control, like I said, is the most important thing. Unfortunately, we only find out the source in 20 to 30% of febrile neutropenic episodes. 80% that's unidentified, we think it's probably just from the patient's endogenous flora. And so nothing grows, and we just go with empiric treatment. It's important to consider in neutropenic fever things beyond infection. So other causes are drug fever, transfusion reaction. You can have fever just because of the cancer itself, atelectasis, DVT, PE, and a lot of other reasons. So it's important to keep a broad differential. From the infectious standpoint, you want to look at commonly cultured organisms, and then you can also look at the funky organisms that may come up in less common situations. For the etiologies, gram-negative bacteria tends to have the most serious infections. The big one that we always worry about, of course, is Pseudomonas. Gram-positives are also very common. Staph epidermidis is actually quite common because of the lines. And really, really potent gram-positives to keep in mind are Staph aureus, especially MRSA, some strep viridans, and enterococci, especially if they have VRE. There's a lot of other bacteria to always keep in mind. C. diff is unfortunately really common, especially on patients who have a lot of antibiotics. Viruses are also things to consider. HSV and VCV are commonly reactivated in seropositive patients who now no longer have immune system to fight. And then finally, the last thing to consider is fungus. They're rarely identified as the cause of initial fever in neutropenia, but most commonly they're identified when you have persistent or recurrent fever beyond the first week. The big ones to consider for these are Aspergillus and Candida. So the treatment for neutropenic fever is, like all infections, give antibiotics. In particular, since these patients don't have an immune system, you really want to get antibiotics on as quickly as possible. So we give empiric antibiotics as soon as cultures are obtained, ideally within less than 1 hour. We give broad anti-pseudomonas beta-lactam agents, so cefepime, you can consider Zosyn, and if they have other drug resistances, then you would consider bigger guns like meropenem. And oftentimes we get vancomycin because these patients have a lot of lines. And ideally, especially if it's a very sticky bug like gram-positives, you may need to remove the line if that's the source of the infection. So here's a breakdown of causes of fever during neutropenia. So unfortunately, 30% are unexplained. And the other causes are gram-positives, and then gram-negatives, and then polymicrobial. So. Empiric antifungal coverage should also be considered in high-risk patients who have persistent fever after 4 to 7 days when they're already on a broad spectrum antibiotics and we still haven't found a source and they're still spiking fevers. So in your write-up where you have your assessment and plan, things you want to consider are the patient themselves, what kind of malignancy and where are they in their treatment. So Hematologic ones like leukemia is at a much higher risk than someone, say, with GI cancer or lung cancer or other solid organ tumors. Patients who are after induction chemotherapy or if they have had stem cell transplant are certainly at higher risk. You want to comment on the risk factors and potential sources. So do they have any lines? Do they have a port? Do they have a Hickman? Do they have a PIC? Do they have a Foley? Comments on their A and C counts. So are they, say, 800? Are they 400? Or are they 0? History of prior infections is really important to consider. If they've had a fungal infection in the past, they're certainly going to be at higher risk. If they've had TB in the past, that's something to consider. And as I mentioned, their transplant status. You want to consider when you triage them and in your write-up, you want to say they're okay to stay on the floor or they're unstable and they'll be moving, say, to the ICU because they are hypotensive and starting to require pressors. Source control, you want to comment if we know what the source is, if they have a Foley, they have burning urination and we think that is probably UTI, or if they've had a lot of coughing up a bloody sputum, they're hypoxic, they've had a infection in the lungs in the past, or is this someone who we still have not identified the source control, or if this is even an infection. Decide on what antibiotics you want to give. It's important to consider what you're covering as well as what you are not covering. And then finally, this is often written in your progress notes and in your H&Ps, the prophylaxis depending on the risk. So just a little bit more detail about that. So usually for patients who are high risk, which are, like I said, are the transplants or the induction chemotherapy for acute leukemias, you certainly want to have them on fluoroquinolone when they're outpatients. Typically, we give levofloxacin 500 daily, or we'll do ciprofloxacin 500 twice daily. You can also give it in moderate risk patients such as lymphoma or multiple myeloma. You also want to give antiviral prophylaxis to patients who are seropositive for HSV. You can give them acyclovir or you can give valacyclovir. And then for a lot of patients, you want to give antifungal prophylaxis. So Candida is by far the most common fungal pathogen in patients with leukemia who were not on antifungal prophylaxis, so you want to make sure that is covered at the very least. Typically, we give fluconazole. Oftentimes, you can also see other things like posaconazole, voriconazole, depending on side effects and what the patient can tolerate. Aspergillus is the most common mold pathogen. And so for these patients, we really would want to cover them with posaconazole and voriconazole as opposed to just fluconazole. If these patients were on these already on the outpatient, then it's really important to use that to determine what antibiotics you are going to give. So in particular for the fungals, if the azoles don't work, then a lot of times inpatient we will move to Cresemba. Of note, Cresemba is not crushable, so if they're intubated, you can't give them that, and you may move on to something like anadulafungin. The other thing of note is for the azoles, a lot of times we are unable to use it because the patient has prolonged QT syndrome. So you really want to consider the side effects when you select your agents to treat your neutropenic fever as well. For case 2, we have an 80-year-old lady with fatigue for the past month. She has severe shortness of breath and she was found to be hypoxic to 85 degrees on room air, so she was brought into the emergency room. Labs that you want to look at and know are she presents with a CBC of 128,000, hemoglobin is 6.5, platelets are 30. For her BNP, her K is 4 and her creatinine is 1, which is her baseline. When you look at the peripheral blood smear, you see that there's 43% blasts. And then when you get a chest x-ray, it looks like this. So for our lady, she has hyperleukocytosis, which is the total leukemia blood cell count greater than 50,000 or 100,000, depending on the cancer, and leukostasis, which is basically hyperleukocytosis that is symptomatic. This is a medical emergency, and it's often seen in AML or CML in blast crisis. So it's characterized by having a very elevated blast count, and symptoms of decreased tissue perfusion. So important things to note is when you have leukostasis, it could be due to either local hypoxemia that's exacerbated by high metabolic activity from basically having a lot of cell turnover, or increased blood viscosity. So the symptoms that you'd want to gather on history and exam are CNS. Have they had headache, dizziness, or any altered mental status? The eyes are commonly affected. You can get vision changes, and shortness of breath and hypoxemia. The lungs are often a site of vascular occlusion, and they typically present with fever. I just do want to make a comment that hyperleukocytosis is not the same as leukostasis. Leukostasis is when you have symptoms, and hyperleukocytosis, you can certainly have a very high white count without having any symptoms at all. Of note, patients with symptoms have a significantly worse prognosis. 20 to 40% die within the first week. So it's really important to capture these patients early. When you're triaging them on your bedside assessments, you want to consider, again, hemodynamic stability, airway, change in mental status, if they're able to protect their airway or not. And then also lab counts, depending on your institution, if you have a white count above a certain threshold, that may be an automatic admission to either the ICU or the step down. And then depending on the treatment you use, it may require them to be in the ICU as well. Sometimes patients may just present with a very high white count and they may be totally asymptomatic. And then if as long as their white count is not above the threshold for that particular unit, then they may be managed, say, on the step down or even the floor if the labs are downtrending in the right direction. For leukostasis, you diagnose it empirically when a patient has leukemia and a white cell classically over 100,000, and when they have symptoms. Most commonly, it's respiratory or neurologic distress. You want to just always have this on your differential, and some patients can have pathologically proven leukostasis even if the white count is below 100,000. So who gets it? In AML patients, it's about 10 to 20% of newly diagnosed AML. Classically, it's in patients who are above 100,000 for their white blood count. For ALL, you can have it in 10 to 30%. Symptoms of leukostasis are rarely seen when they do have the hyperleukocytosis. So what you can see in these patients is tumor, lysis, and DIC. For CLL, actually, a lot of patients have hyperleukocytosis, but it's not very often that they have leukostasis unless the white count exceeds 400,000. And finally, for CML, it's usually patients who present with leukostasis and, again, a white count of about 100,000. Oftentimes, these are when they're immature. Symptoms of leukostasis are pretty uncommon when patients are in the chronic phase. So, like I mentioned, you want to consider, when you look at them, the DIC, TLS, you want to look at infection as well. Oftentimes, you can have infection at the same time, but it's hard to tell between infection and the inflammation associated with the leukostasis, so we usually treat empirically. And then just things to note when you're looking at the patients, you want to use the pulse ox. Sometimes arterial PO2 is falsely decreased, and then the K may be falsely elevated. The treatment for these patients is, of course, to reduce the white blood cell count. So there's two ways you can do it: induction chemotherapy or with cytoreduction with hydroxyurea and leukophoresis. We do recommend trying to do induction chemotherapy first, and then we will do hydroxyurea for patients who, if they're unable to receive immediate induction chemotherapy, say due to other medical comorbidities, or they're acutely ill and can't tolerate it at that moment. Leukophoresis is less commonly done because it requires a large bore central venous catheter, and it's often available only at select medical centers, and it's less standardized, so you don't see it quite as much. You want to make sure that you give the right supportive care for these patients. So you don't want to give red blood cells unless the white blood cell is below 50,000 because of the viscosity. So for our lady who presented in this case number 2, we wouldn't give anything even if her hemoglobin was below 7. You can give platelets. They're much less viscous, and so you can give it with a goal of usually around 20,000 because these patients are often febrile. You want to give tumor lysis prophylaxis, which we will discuss later. And then you also will often give antibiotics because most of these patients do present with fevers and you cannot tell if it's an infection or if it's just from the tumor itself. Just of note, we do give IV fluids for the tumor lysis syndrome. However, you just want to make sure that you don't overhydrate and cause too much volume because that can worsen pulmonary symptoms in particular. So for these patients, when you do your write-up, you want to consider what disease do they have and do they have any symptoms, either clinically or if you look at it on the lab. Again, you want to note if they're stable or unstable, so you triage them appropriately. And do they need treatment, cytoreduction or chemotherapy, or leukapheresis? And that will often help you determine where they need to be triaged, particularly if they need leukapheresis, they will need to go to the ICU. And then you want to monitor labs quite frequently. So depending on the acuity, you may want to monitor it, say, every 6 hours, and then maybe every 12 hours, or then maybe daily if they've already been treated. So you start your treatment on your patient from case 2 with the leukostasis. And you notice the labs are this. So of note, the white count is still 128. The hemoglobin is still 6.5 because, like I said, you don't want to treat the hemoglobin yet with red blood cells until the white blood cell count has gone down. But when you repeat the labs, you notice that the potassium has gone up to 5.8, creatinine is 2.7, LDH has gone up quite a bit, uric acid is 6, calcium is 7, and phos is 6.9. So you're concerned for tumor lysis syndrome that may be developing in this patient. So when you are looking at patients, you want to consider, are they higher risk? So the ones who are most at risk are if they have a high proliferative rate, such as Burkitt's, AML, ALL, high-grade lymphoma. You want to see if they have a large tumor burden, or if they have a high sensitivity to cytotoxic therapy where all the cells start lysing. It is much less common in solid tumors. It's not very common for these patients to present with tumor lysis prior to treatment. And the symptoms that they present with will often match the electrolyte abnormalities. So they may have nausea, vomiting, cardiac dysrhythmias, seizures, muscle cramps. And so what happens is with the cell lysis, you just end up getting lots of potassium, phosphate, and nucleic acids released into the systemic circulation. So for these patients, again, as always, you want to consider the vitals, the mental status, supportive care. So if they need ventilation or if they need dialysis, which can be commonly given if there's renal failure. And you also want to consider when you're triaging patients the frequency of the labs. So if they're on the floor and the nurse has a lot of different patients, even if the patient is stable, if you want to check the labs frequently, the nurse may not be able to handle that and they may need to go to the step down. So I've already mentioned the definition of tumor lysis syndrome and the kind of cancers that present with this. Just of note, things to consider as well, in addition to the large tumor burdens and bulky disease cancers, patients who have renal insufficiency or are dehydrated prior to the start of therapy also are at higher risk. So to define them, there's actually criteria. So you want to look at these particular 4 labs and you want to look at either the values. So uric acid above 8, potassium above 6, phos above 4.5, calcium less than 7, or you want to look at the baseline changes if the patient at baseline has abnormal lab findings. And then that's the lab definition, and then you also have the clinical definition, which is basically lab TLS plus one of the following symptoms. And so it's creatinine that's bumped up, like in Our Lady, if you have new arrhythmias or even sudden death, and if you have seizures. Of note, the one that you really want to worry about is hyperkalemia because of the cardiac arrhythmias, and you can end up having cardiac arrest from that. So for tumor lysis syndrome, the best thing you can do actually is to prevent it. And so preventing it is usually done with IV fluids and hypouricemic agents, either allopurinol or respiracase in patients who are known to be at risk. IV hydration is to improve renal perfusion and glomerular filtration. And so by producing a high urine output, this minimizes the likelihood of uric acid and calcium phosphate precipitation in the tubules. So your goal is actually pretty high. You want to go to 2 to 3 liters a day, and you want to maintain a urine output of about 100 to 200 milliliters an hour. And then for allopurinol, usually we'll give 100 Q8, although you do want to dose reduce by half if they have renal failure. Just of note, allopurinol does not reduce the pre-existing serum uric acid. So if the patient already has hyperuricemia and it's above 8, then you want to give rasburicase because it actually breaks down the uric acid. Just of note, it is extremely expensive. So that's usually given only if you can't use allopurinol. And in patients, especially if they're African American, who you think you're going to give rasburicase, you want to make sure you screen for G6PD. For treatment, if the patient has already presented with tumor lysis syndrome, you want to treat the particular electrolyte abnormality. So if the patient has hyperkalemia, you want to get the EKG, and you want to give them anything that will lower the potassium, so glucose, beta agonist, calcium gluconate if the EKG shows any arrhythmias. And then those are just temporizers. The way to really get the potassium out is to give Kayexalate. Or you could also do dialysis if the patient isn't able to wait for the Kayexalate to occur. For hyperuricemia, like I said, you would just give the allopurinol and rasburicase. If they're already in the treatment phase, then you'll often end up giving the rasburicase, and the allopurinol is more for prophylaxis. For hyperphosphatemia, then you'll just give phos binders for that. Usually don't correct hypocalcemia. Usually don't correct the hypocalcemia due to risk of precipitation in the kidneys. The calcium phosphate product will be increased. Usually we'll only treat the calcium if they have tetany or seizures, and then you would give it to them. For your assessment and plan, and if the patient already has tumor lysis syndrome, you want to consider, is it a lab or a clinical TLS? You want to consider how frequently you want to monitor the labs. So you may do it when they first present, and if they're have very abnormal electrolytes, to do it as often as, say, every 4 hours, and then you can space it out to maybe Q8, Q12, or even daily if you're just already out of the treatment phase. You want to write in your note the prophylaxis measures that they're on. So if they're on allopurinol, if they're on any phos binding products, if they are getting IV fluids or not. Just a note, you want to make sure that you don't overwhelm the patient with fluids, especially if they have underlying cardiac or renal comorbidities. And then you want to write in your note basically what treatment you're going to give them and for each of the electrolyte abnormalities. For our last case, we have a 52-year-old gentleman who presents with gum bleeding, epistasis, and the following labs. So things that you want to look at in particular is the elevated white count, the low hemoglobin, the low platelets. You have low fibrinogen, abnormal coags, elevated D-dimer, and then you have a FISH 1517 translocation, and you have a bone marrow that shows 72% promyelocytes with our rods. So in this patient that you're concerned about DIC, you want to look at the vitals. Oftentimes these patients are very critically ill and usually in the ICU. You want to look at the history and physical, and you want to gather any signs of bleeding, so petechiae, ecchymosis, blood from wounds, IV lines, catheters, mucosal services. You want to also know if they've had, say, clots in the past or if they've had DIC in the past. And then when you're triaging, you want to look at the labs, see how abnormal they are and how much monitoring you will need. And the nursing ratio, again, if you need labs really frequently, then you may need a higher level of care, such as the ICU or the step down. As I said, these patients are very critically ill, so if they need ventilator, dialysis, or pressors. So when you're thinking about DIC, there's a lot of different causes of it. It's not the presentation of something, it's the result of something. So you want to figure out what that something is. Sepsis, cancer, trauma, OB complications are some of the etiologies. What happens in DIC is you have coagulation and fibrinolysis that's just abnormally and often massively activated. And then you end up getting fibrin deposition, and that leads to platelet consumption, coags go down because the factors are getting consumed, and then you get fibrinolysis. So then you get all of the lab abnormalities that we had seen in the case. And then you get impaired coagulation, and then you end up with bleeding. What happens then in DIC is that because you end up getting microvascular thrombosis, you don't get perfusion to the organs, and then you get organ ischemia and failure, and that's when DIC can cause a lot of problems for you and your patient. You want to look at the timing of the DIC. You can have acute and chronic DIC. So when you have acute DIC, you're actually more likely to present with bleeding because you're consuming your fibrinogen and your procoagulant factors. And then you end up having the increased PT, PTT, low fibrinogen, and low platelets. In contrast with chronic DIC, you actually can present with thromboembolic complications because your procoagulants have caught up to the ongoing generation of thrombi, and then you just end up having thrombi everywhere. DIC is both a clinical and a lab diagnosis, so when you order these labs, that is helpful for telling you that you have DIC. And it is important to consider the differential diagnosis in particular for DIC. There's a lot of things that can cause a lot of lab abnormalities. Of note, you can have, say, liver failure, you can have HIT, you can have TTP-HUS, you can have hemophilia, you can have viral infections that cause your, all your labs to go down. Things that could be helpful for differentiating is, of course, the history. So in our case, you have in our particular case, you have a malignancy, and acute promyelocytic leukemia is classically associated with DIC, pancreatic cancer, and other mucin-producing solid tumors as well, such as gastric, prostate, breast, and ovarian. But APML is the really big one that you want to think about if you have that on your history. So when you're looking at the difference between DIC and liver disease, sometimes it can be hard to tell. In particular, with the liver disease, often you'll know that you have liver abnormalities and you'll have elevated LFTs. You can order different coag factors, so you can get 2, 5, 7, and 8. So if you have liver disease, your 8 will be high because that's not produced in the liver, and then you're going to have 5 and 7 are low because those are produced in the liver. If you have DIC, then all of your coagulation factors will be consumed, so everything will be low, including 8. If you have vitamin K deficiency, similar to liver disease, your 8 will be high because that's not related to the liver. 2 and 7 will be low because those are vitamin K dependent. But 5 will be normal because that's not vitamin K dependent, and 5 is made in the liver, and that can help you differentiate. I just want to comment also that D-dimer is not specific at all, and a lot of things can cause elevated D-dimer, such as MI, stroke, SVT, sickle cell, renal disease, and a lot of other things. So our patient in this case has APL, and that's the leukemia that's most strongly associated with DIC. For these patients, if they are not treated, they can die pretty early, especially if the white count is above 10,000. Although if they're able to get through this, they usually enjoy a very good prognosis. You'll see promyelocytes on peripheral blood smear with bundles of R rods, and then often they are 15, 17, sorry, they should say translocation and not transfusion. So you'll see gum bleeding, and you'll see the promyelocytes with bundles of R rods here. Treatment of DIC, especially with APL, can be quite difficult, and you need to monitor the labs quite closely. So you want to check the fibrinogen, the D-dimer, PT, PTT, platelet counts. You want to have a fibrinogen goal of 150 and a platelet goal of about 50 to help control the bleeding. So if you have FFP, cryoprecipitate as options for treating if you're down on coag factors or if you're down on your fibrinogen. You want to give RBC and platelets as needed, and you may need to give heparin if they present with clots. You would want to give heparin as opposed to the other anticoagulation because it's quick on, quick off. Both for active and chronic DIC, you really want to treat the underlying cause because there's always something that's causing the DIC. In this patient with APL, you would want to give atra and arsenic without delay as soon as you think that there's cytologic criteria for it, even if the cytogenetics have not been fully worked up yet. So just of note, you can have another complication from treating your APL, which is differentiation syndrome. And this can occur with when you give the atra and arsenic because you're forcing maturation of the cells. These patients present with cough, shortness of breath, edema, fever, pulmonary infiltrates, and hemorrhage. And just as a side note, for these patients, you would want to give steroids, even if it's unconfirmed, just because of the high mortality rate. And then you would, of course, want to stop the atra. Like I said, APL bleeding is a medical emergency, and there is a high rate of early mortality at about 5%. So for your assessment and plan, you want to write up about if the patient has lab or clinical DIC. Sometimes patients can have DIC without any symptoms of bleeding at all. If it's clinical, then you are, of course, more concerned. If you want to comment if it's acute or chronic, depending on the patient's presentation. You also want to comment on how frequently you check your labs, and you want to write in your note your gold transfusions for your platelets, your red blood cells, and your fibrinogen. And of course, you want to figure out what's causing the DIC, so you would comment on what you think is the underlying cause, if it's cancer, OB, sepsis, and what you're going to do once you figure out the cause and treat it so you can stop the bleeding and clotting dysregulation. All right, this is the end of our presentation. Thank you for following on the heme emergencies. There is the counterpoint to this, which is the oncologic emergencies as well.